Great, thank you. All right, so welcome everyone. This is wonderful to see so many people out and out on Zoom. And Sandra Murphy is going to be presenting today. Sandra's a new graduate, as I think many of us know Sandra. And her presentation today is on childbearing bodies in the healthcare system. So I'm going to turn it over to you, Sandra. Thanks for presenting to us today. And we'll just let you get started when you're ready.
Yeah, sure. So that works, right, with the PowerPoint there?
Yes, it looks great.
Perfect. All right, well, I'm excited to be here and also a little nervous, but I have my glass of water handy to prevent my dry mouth that I get from the nerves. So my name's Sandra Murphy. I am a registered nurse who I completed my Master of Science in Nursing this year at Dalhousie. So I'm here today just to kind of talk a little bit about one of the themes from my research on childbearing bodies in the healthcare system. So just the overview for today, we're going to go through a little bit of background, the methodology, methods, and that kind of thing for my research project. We'll have a brief discussion about embodiment, because, what is that? We'll touch on the healthcare system and what we have currently in terms of perinatal care. And then I'll talk about some of the findings from my research and experiences as a body in the healthcare system, some of the perceptions of nursing and some of the things that the birthing parents in my research experienced. And then I will talk about some of the practice implications that I came up with. So this research was funded by the School of Nursing's Research and Innovation Fund, which gave me money for awesome things like websites and paying for transcriptions, which were a huge help to me as a student. Okay, so my project was called Birthing and Being Birthed. That kind of comes from some of the philosophy and the theoretical underpinnings that were part of the research. This project for me is very personal. The topic came out from a personal experience I had in giving birth, and also professional experiences as a doula and as a student nurse. I kind of came to nursing roundabout in that because of my experience with birth trauma, I wanted to study midwifery, but I ended up at Dal, and through my clinicals, I always thought I would be a perinatal nurse and working in labor and delivery or something like that. But it turns out I really love mental health as well. And a chance interaction with one of my group instructors one time caused me to connect those two areas. And so now I've kind of found my niche in perinatal mental health. So this research does come from kind of my personal experiences, my professional experiences in terms of being a doula and supporting people through their childbearing journeys. And also my practice as a psychiatric nurse, where I deal more with people experiencing acute episodes of mental illness. So a little bit of a summary there. So we'll touch on birth trauma. So in this context, it refers to psychological or emotional distress experienced related to events during childbearing. So sometimes in the literature, birth trauma is a term that's used to describe physical injury. That tends to be an older term in the newer literature on the physical injury, whether that's to the birthing parent or to the baby. It typically refers to birth injury now. So we've seen a change in the terminology there. For my study, I used the definition psychological distress related to events during childbearing. So one other thing that happens in the literature is that a huge part of the focus is on intrapartum, so the time when people are actually in the process of giving birth, and it focuses on the violence and the obstetric intervention that happens during that period. I wanted to capture how that affects people postpartum, but also in a broader sense, what else is happening potentially prenatally or at other times that's affecting people and causing the birth trauma. So there's really basically no consensus on the definition for this. It was my choice to use this definition. It fits really well with the methodology that I was using. You know, and in the literature, you'll also see like things like PTSD, acute stress, PTSD, all kinds of terms, you name it, it's probably been used to describe this. So yeah, no consensus at all. I chose it also because most people are not screened or diagnosed with trauma or even PTSD. A lot of people don't even have awareness of what's happening to them. So it would have been very difficult to find people who were actually diagnosed. So that just kind of added to that there. And some fun stats. So up to 30% of childbearing people experience their birth as traumatic, and about 4 to 9% will meet diagnostic criteria for post-traumatic stress disorder. So by diagnostic criteria, I mean they meet the conditions that the psychiatry manual dictates for them to be diagnosed with a mental illness. Cheryl Beck is one of the kind of major researchers in this area. She was the first to kind of cover this topic, and her research focuses on how birth trauma lies in the eye of the beholder. So birth trauma is something that you as a pregnant or birthing or postpartum person perceive. It's not something that other people tell you happened or that you are experiencing. So it's really something that if you say your birth was traumatic and you're having difficulty afterwards, then that is what happened. You're experiencing birth trauma. I do just want to kind of briefly mention here that we don't do any type of screening or anything for most mental illnesses. This includes birth trauma. So we don't screen universally for depression or anxiety, even though they are one of the most common complications of childbearing. If you consider some of the physical illnesses, so you know, anywhere from 3 to 20% of people will develop gestational diabetes, and around 20% are colonized with group B strep during pregnancy. And we offer screening to everyone for those conditions, but we don't offer screening for mental illness when it's as common or perhaps even more so. Some recent Stats Canada data came out. There was a survey in 2018 and 2019 on people who had given birth in the last little while, the last year or so. So around 23% of that population in Canada met diagnostic criteria for anxiety or depression. And in Nova Scotia, it was 31%, so we're higher than the national average. And again, we're just not doing anything about that at the moment. Saskatchewan, which did implement universal screening, had a rate of 16%, so it's possible that screening would make a difference. So just as an aside, I'm meeting with the reproductive care program next month to talk about this a little bit and see if there is a strategy for implementing screening or treatment for mental illness in Nova Scotia. So hopefully something will come of that. But it is a major public health issue that requires addressing. So in terms of my project, the methodology I used was feminist phenomenology. And those of you who are here and were involved with the project know that I really struggled hard with the feminist part of it. It's not that I'm not a feminist or that I don't believe in feminism. I found, though, that a lot of the literature and the way that feminist theory looks at things is very gendered. And for me, these things are not always only from that lens. So that was challenging for me. But it was a wonderful methodology. I really did end up enjoying it and learning a lot from it. So I also used Merleau-Ponty's perspective on embodiment, and the other for existentials. This presentation is going to focus on embodiment. So with this, I was able to uncover how systemic processes create and contribute to childbearing people's trauma, and some of the structural and institutional reasons that happens. Time for a sip of water. So the methods I used for the research, it was a purposive sample. So then people who were included needed to meet these criteria that you see here. When I started out, I was kind of thinking in my head that I would be looking for lower intervention births. And it wasn't until I actually got into the recruitment that I realized that my inclusion criteria kind of focused more on the pregnancy stuff than they did on birth. So most of the birthing parents, which is what I call the participants, actually had like fairly interventionist births. So an area for future research might be to kind of narrow that down a bit further into births at a lower intervention, and whether or not trauma is affecting people after that. Initially, I'd focused on the first postpartum year, but when I began recruiting, I got inquiries from so many people. It was very slow at first, and then all of a sudden, just a tidal wave of inquiries. I was overwhelmed with responses, and a lot of people were outside of the first postpartum year, and I began to think that perhaps expanding that time frame a little bit might broaden the information that I got in terms of their recovery and the way they were thinking about their trauma and how it was affecting them. So I went back to ethics and had it extended to birthing within the last 5 years, and then also to meet online. Initially, that wasn't a criterion. But I got responses from all over Canada, and I thought that it would be good to have an option for people who weren't in Nova Scotia. In the end, all the participants were in Nova Scotia, and we met in person. So this is a very Nova Scotia-centric project. So the individual interviews, which is where I kind of sat down, it was in the phenomenological method, very broad, mainly a discussion and led by the birthing parents. So those occurred from October 2019 till March 2020. The individual vignette is an audio recording that was done after each session. The birthing parents could choose whether or not to do that. So it was basically me recording their answer to the question, how do I live with this trauma? And they all chose to participate. So there is some audio editing going on with those, and it will be turned into an animated video at some point in the future. I'm still working on that. And then the focus group occurred in March 2020. So this was a way to get people together for me to present my initial findings, see what the birthing parents thought, and get their feedback. Any, is this what you think, or did I totally interpret this wrong? Do you have anything to add? Because for some of them, it had been a few months since we'd chatted. So it was time for them to kind of process what was going on. Maybe they had additional thoughts. So that happened in March 2020. It actually happened on the very day that the first COVID restrictions happened. So I got a few cancellations. And in the end, 2 people attended the focus group, and they ate a lot of prosciutto. It was awesome. Okay. So this is who the birthing parents were. So 6 in total. It's a small sample size because phenomenology relies on in-depth. So we really got into depth in the conversations with the parents. There's not too much diversity here in terms of age, their gender, their sexual orientation. There's some diversity in educational stuff and some diversity in socioeconomic status, although they are on the higher end of the, the median income kind of thing. So I do think in future, for any projects I do with this, or if any of you are considering research in this area, that it might be good to be maybe more selective in the people who are chosen, just to represent some additional diversity. All right, now we get into the fun stuff. So embodiment, it's a fundamental part of Merleau-Ponty's philosophy. And actually a lot of philosophers and even just movements now talk about embodiment a lot and what it means to live in a body. So it's there's all kinds of ways you can go with this. I'm going to focus on what I used for my research. So there's kind of two different schools of thought, and I'm not going to get too much into it, even though it's a very interesting conversation to have. So some philosophers are into the idea that your mind can be separated from your body, and that it kind of can exist on its own out somewhere, I guess, outside of your skull, and that those concepts are separate. We can see our body as something that's outside of us at some point. Others come from the school of thought where you cannot do that. So your body is kind of something that you're in, you are your body, you cannot escape it, and we perceive everything through the window of our body. So that second one there is the one that I used for this. So we perceive everything through the window of our body. We're not able to get outside of that, and that our perspective and our interactions with the world, our body is a fundamental part of that. And then we have this concept of pregnant embodiment. So pregnancy is kind of a unique bodily state, you might say. There's Iris Young has some very interesting work on this topic. And it's, in a sense, a way of an embodied transformation. So when you're, thinking about getting pregnant, or you are pregnant, or you're birthing, even postpartum, that whole childbearing period, your body's undergoing a transformation. And you notice that, when you look at yourself, say you look at yourself in the mirror, you see, body's changing, things are getting bigger, and then you feel it internally too. And that when you're pregnant, you have a fetus inside you and you can feel it moving. So it's really like an odd state to be in that's very unique to, a certain portion of our human population. In a sense, childbirth in itself is kind of a separation of the self. So there's this idea that while you kind of logically know that your fetus inside you is not kind of you, it is you in another way, and that it's part of your body. So we have a lot of things going on in our bodies that we're not really in control of. And we feel these sensations, and we don't typically think of these sensations as not being part of ourselves. But when it's a baby in there, we have this idea that it's actually not us, even though it could be seen as the same sensations, if you all get what I mean. It's a little bit of an interesting, confusing conversation. And just to talk a little bit about this merging of biological processes and social constructions. So I find that a lot of feminist research of late is really focused on social construction. And I love it. It's great. I think it's important to think about how social processes and institutions and structures and things affect us. I also think that because we can't escape our bodies, that we have a lot of stuff going on in there that is uniquely biological to being pregnant or being female or other such states. And I think it's important to acknowledge that there is really like a biological perspective on this too. That's kind of where I come from, and some of that has influenced some of the findings of my research, particularly in terms of what the birthing parents were experiencing in terms of symptoms and things. There are biological underpinnings for that, as well as the social construction of childbirth and how we expect people to act when they have a baby. And our healthcare system. So just a brief overview. And I will fully disclose that I'm totally biased towards midwifery, which is kind of, you might see this a little bit here. I grew up in a country where midwives are the primary caregivers for childbearing people, and I think it's really weird that Canada doesn't have that. But it is what it is. Physicians are important too. We do need a variety of care providers. So in terms of pregnancy care in Canada, it is a physician-dominated model. The majority of births occur in hospitals. In some areas of the country, there are birth centers, which are typically staffed by midwives, where you can have kind of an in-between between the hospital and home. Home birth is not very common here. So 11.8% of births were attended by a midwife in 2018. Less than that would have been home births, because not all people who have midwifery care can or want to have a home birth. So they do attend births in hospital too. In terms of accessing care, Nova Scotia has a really low rate of midwifery attended births. It's mostly due to the fact that there have been government roadblocks in terms of funding and getting people here to work. Across the country, people are traveling quite far sometimes, especially if you live in a rural area. You might have to travel for hours to access care. And then some people in northern communities, our Indigenous peoples, are being asked to fly out of their communities to other places to have their babies. And even in, that sounds kind of out of touch with Nova Scotia, but it's a reality for people in northern communities. But also even in Nova Scotia, like say you live in Digby, you can't give birth in Digby. There are no midwives there, and there's no hospital that does births. So you would need to travel, and maybe for your prenatal care, and definitely in order to have your baby. So it's something that happens here too. I bring this up because these things contribute to people's trauma, being forced to leave your community, leave your, your other kids, your partner, your family, and all your supports behind, is something that contributes to people's birth trauma. Having choices really matters in birth. So if we can offer a more holistic and choice-based system, we might see lower rates of birth trauma. And I find it interesting just to bring up, and I'd love to hear your thoughts on this kind of thing at the end, about how in other healthcare contexts, and access to a provider is kind of a triage-based system. Right care, right place, right time is something that NSHA has as one of its slogans. For example, you wouldn't see a cardiac surgeon if you only had hypertension and no other symptoms. If you're pregnant though and you have hypertension, you'll see a surgeon for your care, and it's unlikely that you'll be allowed to go back to your initial care provider. Your care will be transferred to the surgeon. So something to think about, food for thought. So now to the fun stuff, some of the findings from my research. I'll just say, so when I started out, this did start as a postpartum kind of study. I was focused on the postpartum period and how parents were living with their birth trauma. When I got into talking with them though, it kind of became evident that the trauma wasn't only related to things that were happening during birth, like the literature has suggested, and that some of the things that were happening in the prenatal period, and also postpartum were contributing to or exacerbating people's difficulties with their trauma. So part of this is framed around this idea of metaphysical violence, which is a wonderful work to read if you're at all into philosophy or feminist phenomenology. These two authors have written a couple of really wonderful articles on this, and specifically related to obstetric violence. So it fit really well into the work that I have done. So there are kind of core concepts of it. We have a system that prioritizes the knowledge of medicine over the knowledge of individuals and social knowledge. So violence happens when people don't have the language to describe what's happening, or they are unable to understand the language of others. So when these things happen, people have trouble understanding what's going on in their worlds. So one of the things I noticed in my research was that the birthing parents didn't have the language to describe what was going on with them. And the care providers didn't bring it up, first of all, but they also didn't understand what care providers were saying. So one of the things that happened, interestingly, during my individual interviews was that the birthing parent and I were able to kind of communicate, or I was able to communicate to them and they to me what was happening. So I acted in a way as a translator between what they were experiencing and what the healthcare system said they were experiencing. So part of metaphysical violence too is the idea that the standardization of care promotes that childbearing bodies are the same and should be treated the same, which kind of ignores the powerful like pregnancy and the birthing person that they actually are. That's how I see them anyway, and a lot of other people do too. So individuals' needs are, not unique. They need to fit into the box. And childbearing people, this is a quote from Wolf, are seen as vessels that the system must attend to in order to produce healthy babies. So in perinatal care, there is a lot of focus on babies, fetuses, and it comes at the expense of the care of the person who's pregnant or just gave birth or is giving birth. So we typically don't see some of the things that happen during the perinatal period as violent. However, metaphysical violence is present whether we see it or not. Wolf does give some wonderful examples of things that are seen as violent. So things like standardized vaginal exams to check for dilation and things, and the regular use of assisted delivery and things like that, standardized prenatal care. She lists a lot of issues with that. So the first kind of finding, I'm going to discuss was the idea of navigating pregnancy care. So I didn't expect this like prenatal or during pregnancy stuff to come up. I wanted it to be focused on postpartum, but one of the things when you're doing your project is to be open to what the participants are saying. And so I really heard loud and clear that a lot of the stuff in our system was contributing to their subsequent trauma postpartum. So they were pretty confused because most of them were first-time parents. They were a bit confused about how the system works. So most of them didn't have a primary care provider who attended births. So they initially saw that provider when they figured they were pregnant. And that provider then kind of told them, well, I'll need to refer you to someone else. So the someone else was always a physician. None of the primary care providers referred anyone to a midwife. Those birthing parents who did access midwifery care did so on their own, and it was primarily at the recommendation of people in their social networks. So their friends and their family were recommending midwifery care, and it was almost always, interestingly, presented as a positive, better option. Of course, my bias has me agreeing with that, but recognizing that some people maybe don't want that type of care and do prefer a more medical focus for their care. They felt that there was really limited choice in care provider because of this. So, when you're referred to any other specialist, you don't really get a choice in who that person is. You might get a choice in their profession. However, in this context, all the birthing parents were referred to an obstetrician, not another family physician, say, who did attend births. So they felt that they really were limited in their choice. Also limited in choice of birthplace. So hospitals were the major option. If they had a midwife, they sometimes had an option for a home birth, but all the births took place in the hospital for the people in this study. Those who did have midwives said that they liked the continuity of care, so they saw the same person for their care. Some of the people who had physicians would see different physicians at a clinic, which they found a little bit difficult to cope with, because they were worried about, I guess, who might show up for the birth. They wanted to have the same person there. And they felt kind of powerless in these decisions. It was like these decisions were made outside of their control. They weren't really involved in the decision. They couldn't, for example, say, I don't want to see this physician. Can you refer me to a different one? They didn't really feel like they had choice. Yeah, so that's a way that our system enacts violence upon people, through limiting their choices. And you can kind of see how that happens at a policy level, where we have this model that's really medically oriented, and we fund that, and then we don't fund alternative ways of care, even though midwives are specialists in giving birth. And the same with birthplace. There's no birth center in Nova Scotia. It would be a great option for a lot of people. So the second theme here was birthing bodies as objects for control. So we have some quotes from the birthing parents on the right-hand side there. I just chose a one for each slide that I thought was appropriate. So really common in the birth trauma literature is this concept of birthing parents feeling they're not in control of what's happening to them. So it can be something that just happens generally during birth. It's a process that you're not really in control of. But what people talk about in terms of not feeling in control is that they're not involved in any way in the decision making in terms of interventions or positions or where do I give birth kind of thing. So the birthing parents definitely described examples of this. The system just saw them as kind of a body giving birth and not as a person giving birth. In terms of procedures not being explained, so Elizabeth, one of the birthing parents, described how her care team suggested that they might need to use a vacuum. And she in her head was thinking of forceps. And so she kept saying, no, I don't want that. But the care team insisted. And what is interesting about this situation is that there's kind of a lack of communication there, and that the care team is saying one thing and meaning one thing, but then Elizabeth is hearing and thinking something else. So in a sense, this is also an example of the normalization of the violence, and that the care team doesn't recognize that the birthing person doesn't understand. It's so normalized for them to use interventions that they forget sometimes that what's routine for them is not routine for the person who's giving birth. So the third theme, this was kind of a postpartum theme. So birthing parents felt once they were discharged from the hospital that they were just like abandoned by the system. So they were discharged, went home, and that's kind of it. Their contact with the healthcare system was pretty well done, unless they went to their 6-week checkup. Some of them did have primary care providers who would get the baby in more frequently than that. And for one person, their care provider did check in on their mental health, but generally any mention of mental health was absent in their perinatal care. So at no time in their prenatal care or postpartum was any type of like mental health discussed. So no screening, no acknowledgement that this is a very common thing that happens to people, that it's not just postpartum depression, there are other illnesses that people experience. So that was kind of a disturbing realization. Also noted here is that the birthing parents really wanted healthcare providers to check in on their mental health. The birthing parents did kind of realize that something wasn't quite right. They didn't feel right, that they thought this wasn't quite a quote normal like transition to parenting, but they weren't quite sure what was going on. But they were also at the same time afraid to bring it up in case something was wrong. So they kind of sometimes would read about postpartum depression, but it didn't really like fit what they were experiencing. So instead of mentioning that to their care provider, they just took it on themselves to work out what was going on or just live with it. So that they kind of just kept quiet and continued to like blame themselves for their apparent failures. So as as healthcare providers, and I know most of us here are nurses, it's very important to be proactively initiating conversations with your patients, which I'll touch on a little bit more later, but so important. So those are the 3 themes that I'm going to talk about today. There were more, but you can read my thesis if you want to know the others. And just as a caution on this next section, I found it very disturbing what the birthing parents had to say about the nursing care, because overall it was very negative. And I remember like, going through the transcripts and collating what I was finding and things, and going to Lisa and just saying, what am I gonna do? Like, this is so negative. I don't want to write something that is just a tirade on nurses, right? I'm a nurse. I struggle with these same things at work. So she was wonderful in suggesting that, we could look at this from more of a structural and institutional perspective rather than focusing on the actions of individuals. It's kind of unfortunate in a way, though, that the birthing parents don't see it that way, because their focus is more on those like individual level interactions. So and they also, like, because they are traumatized, one of the things with trauma is people tend to have like negative thinking patterns. And so they do have like really negative things to say. So I just want to like have a caution before we jump into this section. We all have a lot of responsibilities when we're at work to all kinds of people, but the priority needs to be patient or client or birthing person care. And I struggle with this stuff too at work. It's not unique to any one area of nursing, right? So the first thing birthing parents noticed was that the nursing care they received was reactive. So by this, it means that the birthing parents were the ones initiating conversations or asking for things or asking questions. There was very little kind of initiation of conversations by the nurses who were in these environments. So that includes like the prenatal care and postpartum. It didn't apply so much to intrapartum. Their memories of that were kind of fixated on what went wrong, less about the nursing care. So Sylvie was funny when she had a special chair, I guess, that she asked to sit in, and she said this about the nurse sitting in that very chair. The nurses seemed to just, in that case, like lack situational awareness. So an awareness of what's going on in the room, what should I do, what should I say, how are these people doing emotionally, that kind of thing. And they also appeared to be burdened with tasks. So, you know, there's a lot of stuff we have to get done, a lot of charting, a lot of check boxes, you know, all that kind of things. And the birthing parents noted that that seemed to be a thing that the nurses were burdened with at the expense of interacting face-to-face with the people who had just given birth. So there was also just uncertain communications. So nurses did really well in emergent situations. So, you know, Sylvie tells a wonderful story about how when her, you know, there was an issue during her labor and the nurses just came out of nowhere, were calm and collected, explained what was going on and what was going to happen, and, you know, did wonderfully. There's that normalization of obstetric intervention again. So it's kind of similar to before. So nurses not really being involved with explaining what was happening or why at other times. And then a lot of inappropriate comments. I just have one example to go over. So Sylvie was, as she describes it, wheeled back for her C-section. And a nurse said to her, "And remember, you got to 9.5 centimeters." So I mean, I think probably this comment was meant as, look how strong you are. You did so well. You got really far, you know. But Sylvie interpreted that as just a failure. Her body failed her. She has to now have a C-section. And she actually like thought about it and ruminated on it for months postpartum. So there was some stuff postpartum that was confusing for people as well. And that, so say like the nurses on one unit told the birthing parents to look out for certain things, but then the nurses that looked after them postpartum would say something different. So that like the size of clots, or how often you should breastfeed, or, you know, when is it a problem if I can't like urinate after I give birth, those kinds of things. There was mixed messaging on those things. This one here is like invisible nurses, refers a lot to kind of more the postpartum care, because the birth nurses are present constantly, which is wonderful. They do a great job. One of the birthing parents did actually say like the birth nurse was wonderful. So some positive feedback too. In terms of postpartum, so birthing parents had trouble getting a nurse to their room to help them. There's a quote from Elizabeth Bear on the right, which kind of sums it up. That was a pretty extreme experience, but others had something similar. It was just hard to get people down, and when they did come in, they weren't always happy about it. In terms of once they went home, some birthing parents received a postpartum visit from public health, which some of them found really helpful. It was just one visit though, and the birthing parents did say that they could have benefited from more support. So in Nova Scotia, everyone who's had a baby is screened at their birthplace or in hospital, mostly, by a public health nurse, and that kind of determines what kind of support you get. So some people get enhanced support, some people will have a phone call, and then some people will get a home visit. It just depends how you're screened. I don't know, I kind of struggle with that a little bit, just in terms of the idea that just because you screen a certain way doesn't mean you don't need extra support. But I know I understand this has to happen in a context where we have limited resources and everyone can't get extra support, that a line has to be drawn somewhere. But I think it's really doing a disservice to postpartum people to not have support. I wish it was more like midwifery care for everyone postpartum, but nurses doing it, that would be awesome. So outside of the public health nurses, if you want extra support, you will need to pay for it for the most part. So whether that's a lactation consultant or a postpartum doula, or nurses who come and support you, if you have the money, you'll be able to access that. One thing that the birthing parents also astutely noticed, no mental health nurses were involved in their care at all. It's kind of something I struggle with a little bit, because I'm one of those nurses who kind of crosses these two areas of nursing. It is a specialty area, and I think we should have more people trained in both areas. And considering that mental illness is a huge complication of pregnancy and very common, that we might want to consider having more mental health content in these perinatal environments. So practice implications. Education was a huge one. One thing I found is that there was just all over the map, just a bit of a total lack of awareness about trauma specifically. There was some awareness of depression, but really people's of and associations really stop at postpartum depression. It doesn't extend to other illnesses. So any of the illnesses can present in the perinatal period. So anxiety, OCD, bipolar disorder, psychosis, all that stuff can happen at any time while you're childbearing. So one of the things that needs to be developed is information or some sort of education module specific to each of these populations. I suggest different ones for these populations, because the language that care providers use is going to be different than birthing parents. So we might want to have some a kind of professional and then more family-oriented resources. Also, Canadian-specific resources. So the NHS in the UK has a ton of awesome information online. They're about 20 years ahead of us in birth trauma and all mental illness. And there's wonderful information there. However, it is very UK oriented, and a lot of it won't translate very well to a Canadian context. So I am in the process of updating the website that I used for my recruitment to have some Nova Scotia specific resources for birth trauma for people to find. And interestingly, a fun fact, the birthing parents said that I had this brief blurb here on my website with just very minimal descriptions of what you might experience if you're traumatized by your birth. And a number of them said that it was the first time that they recognized themselves in any type of literature or description of a postpartum mental illness. And the first time that they'd realized that they might not be the only one experiencing this. So this just kind of speaks to how easy it might be to identify people and get them the help that they need. That's one implication. And mental health supports it just came up again and again, typically in the absence of mental health in perinatal contexts at all. So for practice, we really need mental health professionals in those environments. And I'm not talking we have a reproductive mental health team, and they do wonders with, the resources that they have. But this is something that needs to be encompassed and brought into and normalized in just prenatal care in general. So things like, even if we just screen for depression to start with, that would be a great place to start, or to have more, social workers, nurses, psychiatrists, et cetera, who are trained with this and know things about this specific population. I think screening is imperative. It's so important. There are, of course, lots of arguments for not screening, because what are we going to do with the people who screen positive because we don't have resources to refer them to, et cetera, et cetera. I just think it's really important to be screening so that people have answers for what they're experiencing. And then also in terms of system planning, how big is the problem and what do we need to do in order to address it? And peer support groups are a huge help for people. Obviously not for everyone, but in terms of postpartum depression, the research shows us that peer support is, it improves people's symptoms and they are depressed for a shorter period of time. So there's no reason this wouldn't work in terms of birth trauma. I actually took a training recently on a curriculum for a peer support group. So that's something that's on my radar to modify for a Canadian context and start one up somehow online in the near future. Sometimes that's all. Questions, conversations.
Great. Thank you so much, Sandra. Powerful research, and I was one of the lucky ones to be on your committee. And thank you so much for presenting this really important work. So we have about 5 minutes for questions and comments. I'll open it up to the audience. Great. So feel free to open up your microphones and say things. I know we also have the chat bar if people are having difficulties with their microphone. And it'd be great to turn your videos on too, if we can see you as you're speaking.
Leah, thanks for your congratulations. I'll send you a photo of me in my silly hat.
Yeah, I hope you got lots of pictures.
Well, I mean, I don't need to ask questions because I'm the supervisor, but if no one's asking questions, I, of course, can, more of a comment, Sandra, that disconnect between the nurses' comments and language and the participants, like that, especially that one about, you made it to 9.5 centimeters, and how that person took that away and that sat with them for such a long time. That's an interesting thing, because I could see how, as a clinician, you would think that was a positive comment, right? So how do we do that education about that disconnection between that kind of language where a nurse thinks that's a really positive thing to say, yet for the person who's birthing, that really is not something positive. So how does that educational piece, how do we do that so that disconnection doesn't continue to exist?
Yeah, I think like anything in nursing, there's a level of reflection that could perhaps occur, and it's possible that people do that, but reflecting on the things that you say and how they might be interpreted. Then I also think there are lots of opportunities for nurses to hear about the way things they're saying are being interpreted.
Yeah.
And I guess in the context of perinatal care, it doesn't, you kind of don't have an ongoing over the next few weeks kind of interaction with people. So like, for example, where I work, if I say something that's perceived the wrong way, the person will tell me in one way or another. Yeah. They're not always nice about it.
Right.
but you have an opportunity, because the patients I work with are with us for a few weeks generally on average, to work with them over time and to kind of say how you didn't intend it to be that way. But then it also gives me feedback on how perhaps I would reconsider that in the future. So I think, and like for perinatal nurses, it might be beneficial to hear from birthing people that, that did affect me in this way.
Yeah, yeah. So that, a workshop on trauma-informed language and communication would be a really wonderful thing to do.
Yeah.
I think, because that ongoing relationship is not there. You're in, you're out. So I think that's something to think about for the future around a teaching tool for that.
Yeah. I'm actually collaborating with the IWK on an education module for nurses, like in terms of perinatal mental illness, and because the nurses I work with don't know anything really about perinatal stuff. They're terrified of breastfeeding and babies and all that kind of thing, and I think it's probably the opposite for perinatal nurses. So we're working on some education that will kind of help with that. So I'll add that to the list of things.
So I think that's great. Wonderful. Thank you.
Great. Comments or questions from anyone else? We have about 2 minutes.
Hi, Sandra. It's Brianna. Sorry, I'm eating my lunch at the same time. I just wanted to say this was almost like a trauma-informed workshop for me. I'm going into a night shift tonight, and it was nice just to hear all the amazing work that you've done. And I think it is really impactful for you to bring this through and share it with clinician nurses, because it is just hearing that again, like that example that Lisa just brought up too, that you had brought through your research about that, what was intended to be a positive comment to that mom, or that parents, it was just like another moment of having to check yourself and always try and reflect. And I think kind of above all, just recognizing when parents have had a birth trauma, kind of that it is traumatic, and maybe that being the first thing that you address with the parents before kind of moving on to trying to see the light or the kind of like silver lining, I guess. But I just want to say thank you, and I'm glad that I was able to join, because now just kind of have that lens as I go into my shift tonight. Yeah, and great work. Can't believe it.
Thank you. Tell your colleagues.
Well, yes, yeah. And so I'm working in Prince Edward Island, so anything that you have to share here as well, like not just kind of through the IWK, I'd love to bring it to them.
Yeah, there's another master's student in New Brunswick who's doing a project on birth trauma too, so keep an eye out for her research as well.
Yes, awesome.
I can email it to you.
Yeah, that would be great if you don't mind. I'd love that. Yeah.
I was just going to say thank you so much, Sandra, for sharing, and for everyone else who came here. And just as you have said, we need to share Sandra's work. So taking that, sharing the findings, and directing them back to you, Sandra, also. So thank you so much. I see it's 1 o'clock, and that's a wrap.